Okay, well, welcome back after Thanksgiving. Hope everybody's rested and ready for the last 2 weeks of classes, and then we'll move into finals, and then we'll get you back on break for a little while. And then I believe that you guys are you're back in class, and then you go out in your clinicals when you return in January. So next topic up, SI joint examination and treatment. Hopefully you're listening to this lecture prior to lab. We're going to be covering this topic in lab on Tuesday and Wednesday of this week. So having watched this, you'll be prepared. Now, my apologies for substituting this online lecture in place of live lecture. I'm sure some of you are happy not getting up at 8 a.m., but I think it's always better to meet and have the opportunity to ask and answer questions. I think it also helps to pace the lecture, as I tend to get going a little bit faster when there's not the feedback from the class about how you're understanding the material and asking questions. So having said that, let's go ahead. So the SI joint, the issue with the SI joint is there's a lot of debate among clinicians about whether there really truly is SI joint dysfunction, and I think that the majority of clinicians, if not all, would agree that there are patients that present with SI joint dysfunction. The true challenge is trying to differentiate the patient that truly has an SI joint problem from the patient that has a lumbar spine problem, or even a hip or pelvic problem. And so I think that's where the debate comes in, and so the true incidence of SI joint pain and dysfunction probably is more unknown than known. One of the reasons for this is that most patients that have pain in their SI region, so they indicate an area of pain over the buttock area as the main part of their pain, they truly do not have SI joint disorders. And so just having that symptom complaint of pain in the over the SI joint or the dimple of the buttock is not an indicator that the problem is coming from the SI joint. One of the reasons that patients that have lumbar spine pain or dysfunction present with pain over the SI joint is the SI joint is innervated from the nerve roots L2 to S4. And so based on that, it's easy to see how a patient can have referred pain from the lumbar spine but be experiencing the pain in the buttock or SI joint region. And so lumbar spine pain can refer to the SI region or the buttock region. So with this difficulty, this awareness of the challenge of identifying the patient that truly has SI joint dysfunction, the approach that we typically use in the clinic is to try and build a preponderance of the evidence. In other words, try and build a case or a pattern that suggests the patient has SI joint dysfunction. And then the true diagnosis lies in when treatments are directed at the SI joint that either decrease or resolve their pain, we can conclude that that patient likely had an SI joint dysfunction. So again, it's a preponderance of the evidence. And the reason for this approach is historically the tests that we've used to identify SI joint dysfunction are not highly diagnostic. And by that we mean they have poor validity, poor reliability, and sensitivity and specificity of the tests are not really all that high or good, and that makes these tests not very useful in our diagnostic approach to these patients. Now, more recently, some evidence has been coming out regarding a subset of SI joint tests that are showing a higher level of especially sensitivity and specificity for the tests, and as a result, we're getting better at being able to identify that patient that presents with SI joint dysfunction. And so the approach in the clinic is that traditionally we've used tests that did not have good validity, reliability, or sensitivity and specificity. And so we would try and use a series of tests. The difficulty now is that some clinicians still only utilize those tests with poor psychometrics, if you will, for diagnosing SI joint. And so to some degree they have this high value reputation in the clinic when in fact they're not very diagnostic, or they're not a useful diagnostic tool. And we'll talk about that as we go through. But what we typically see is we try and build a case or build a pattern using several groups of tests that are intended to determine whether a patient has SI joint dysfunction. And so this pattern begins with what do their symptoms present like. And the first one is that their pain never really, or SI joint pain has been shown to never really cross the midline. And so patients will not describe a pain pattern that would be this across the lower back and then a majority of the pain into the buttock. Patients with true SI joint dysfunction will describe their pain as being localized to the SI joint and buttock. They may also describe some pain that radiates down into the posterior thigh. The reason that we know this is that research where the SI joint is injected with saline to produce a distension of the joint, and then look at the pain pattern, and it creates this kind of pain pattern. So it does not cross the midline, and it's unilateral buttock, maybe with or without thigh pain. Some patients will describe anterior pain in the pelvis, which may extend into the groin. And the question about why here is if you think about the pelvis, and we often describe the pelvis as as being a junction of two innominate bones. So that is innominate, innominate, innominate. And so there's a right innominate and a left innominate that articulate with the sacrum posteriorly. So they articulate with the sacrum posteriorly and with each other anteriorly at the pubic symphysis. And so a lot of SI joint dysfunction is a result of a displacement or a positional fault of one innominate on the other. And it leads to SI joint pain and dysfunction posteriorly, but with the articulation at the pubic symphysis, motion that occurs at the SI joint posteriorly is going to create movement at the pubic symphysis. And so this positional change at the pubic symphysis can lead to pain over the pubic symphysis. And since the anterior innominate is the proximal insertion of the hip adductors, adductors, it can lead to pain or radiating referred pain down into the groin following the adductor musculature. These patients will often have increases in pain with weight transference. So as they transfer weight to and from the involved side, so with gait, as they go from a non-weight bearing to a weight bearing phase during the gait cycle, they will experience increases in pain with weight bearing and decreases in pain with non-weight bearing. They also describe pain with transitional movements, and by transitional movements I mean as they go from sitting to standing or standing to sitting, from supine to sitting and back again. They often experience it with going up or down stairs, with that weight transference and that rotational movement that can occur. SI joint dysfunction is also common during pregnancy, especially in the late third trimester. And so during that phase of pregnancy, hormones are released that have the action of increasing the mobility or flexibility within joints intended for the pelvis in preparation for labor and delivery. And with this increase in mobility, patients can start to experience some SI joint dysfunction. And then lastly, SI joint dysfunction can often be brought on or made worse with repetitive, vigorous activity. And with this one, I always think of the football punter. And so when they repeatedly and forcefully flex one hip with an extended knee, that lengthens the hamstring, which attaches to the ischial tuberosity of the innominate and creates this posterior pelvic rotational force on one side of the pelvis, while the opposite side is being pulled into an anterior pelvic tilt from the hip flexor musculature. And so this internal pelvic torsion can lead to the onset of SI joint pain And so you can imagine that torsional or rotational force being directed to the pelvis with those types of activities. And so this is not just with punters, but I use that as a way to help me to understand this repetitive, vigorous activity. And then lastly, as was just described, SI joint dysfunction often presents with postural faults and tight hip musculature. And so very similar to that punter, if I have a one-sided issue where I have, let's say, one-sided tight hip flexors that are constantly pulling the pelvis on that, or that innominate on that side of the pelvis, into an anterior rotation, it might start to lead to pain and dysfunction at the SI joint. So I'm going to talk about a brief anatomy review, and then how do we go about testing the SI joint in a clinical situation. And we're going to talk about 3 groups of tests. We're going to talk about palpation-based tests, motion-based tests, and stress-based tests. And then we'll get into a little bit of treatment. We're going to give you some ideas of ways to treat the SI joint, but there's a whole school of thought related to SI joint, and we're just going to try and give you, I guess I would call a brief introduction, but at the same time, I think will make you very able to identify the patient that does have SI joint dysfunction, and will have some tools in your toolbox to start to address some of the common and typical SI joint presentations. But I want you to be aware that there is a variety of continuing education that you can attend to learn more about both pelvic issues at the SI joint and sacral issues at the SI joint. So kind of an interesting area of the body to be focused on. So quickly, with an anatomy review, if you reflect back on your experience in the cadaver lab and looking at the pelvis and the SI joint, you should recall that there were some very significant ligaments that bind the joint together. And at that time, you may have been asked to think about, or you may have even asked yourself, geez, why are these ligaments so big and broad and tough, very difficult to cut through? And one of the reasons for this is it's a point where all of the body weight is being either transferred from above down to below to the ground, or the forces from the ground are being transmitted up the leg and up to the spine. And so it's an area that is subjected to significant forces that could lead to motion and dysfunction, and as a result, you build up some pretty tough and strong ligaments to help to support that joint. The second reason that you see a lot of stability in the joint is you have a wedge-shaped sacrum that fits tightly into the iliums, or again those 2 innominate bones. And so when you have a stable pelvis created by these 2 innominates that receives the wedge-shaped sacrum, that wedge shape almost acts to separate the 2 innominates while the ligaments help to hold it together. The result is that you have a pretty stable and steady SI joint. And so way down below, which is really hard to see, it says result is minimal joint motion with a maximum of 3 to 5 millimeters of motion. And this is, again, a source of debate among clinicians. And really the debate is there motion that is occurring at the SI joint? And you'll hear some clinicians say that, yes, there is motion available, but there is no motion that occurs because of some of these anatomical features. While others will say, yes, there is motion, and it does move 3 to 5 millimeters. The difficulty is that I think clinicians agree that the maximum amount of motion is 3 to 5 millimeters. But with that in mind, a lot of our examination techniques are directed at trying to determine whether there's been displacement or motion in the SI joint. And again, that motion would have been at maximum 5 millimeters. And so trying to detect that 5 millimeter change in position from right to left can be quite challenging. The last thing that I want to point out is if you recall the joint surfaces of the sacrum where it articulates with the innominate or the ilium, and then the ilium where it articulates with the sacrum. So those two joint surfaces are not smooth like we typically think of with synovial joints, and there's a lot of roughness, if you will, hills and valleys that as a result create a lot of stability within the joint. And the way that I think about this is if you were to take your two hands and make fists and then point your fists towards each other, and where your knuckles are, where you have hills and valleys, if you were to place the hills of the knuckles of one hand into the valleys of the knuckles of the other hand, and then press your fists together, if you were to try and slide one hand away from you or towards you on the other, you'll see that interlocking of the hills and valleys creates stability. And so this is another source of the stability within the SI joint. So putting those fists together and then that little pressure together and then attempt to slide one on the other, resisted by the hills and valleys, gives you an understanding of the SI joint stability. So again, all superincumbent weight is transferred to the lower extremities by passing through the SI joints, which ultimately then passes to the ground. Or if you were to jump and land, that ground reaction force passes up through the leg, through the pelvis, through the SI joint, and then up through the rest of the body. And so again, there's a lot of forces being transmitted through this joint. Therefore, we need a quite stable joint. And so this joint is truly quite stable in nature, and it resists a lot of motion. And again, the maximum amount of motion that you experience at that joint is 3 to 5 millimeters. Again, a source of debate among clinicians. Some say no motion, some say some motion, but I think all would agree that if there is motion, the maximum is 3 to 5 millimeters. So the next kind of step in our thought process is, well, what could go wrong at that SI joint if it's a pretty tough and stable joint, has the ability for very minimal motion? If it is truly that stable, what could go wrong? And so the first thing that we think about is movements or subluxations of the ilium or the innominates, which again, the innominate is the fusion of three bones, and then there's two innominates in the pelvis. But movements or subluxations of the ilium on the sacrum, innominate on the sacrum. We can get movements of the sacrum on the ilium, and some of these movements can be described, and again, this is either the ilium on the sacrum or the sacrum on the ilium. But as we describe these, an upslip would be let's say the right innominate has moved upward superiorly on a fixed sacrum, so it's slipped upwardly. So an upslip is a movement or displacement of the innominate on the sacrum in an upward direction. By the same token, we can have a downslip, and so the innominate or ilium moves downwardly on a fixed sacrum. Just to help you to understand upslips, if you were to stand right now and jump up in the air and land on one leg with an extended knee, you'd feel that force going up your leg, transmitted to the pelvis, and at the same time your body weight is accelerating downward towards the ground, and when your foot hits the ground, that motion stops. But the momentum of the body would carry the trunk and the sacrum downward on a fixed innominate of the landing leg, and it could create an upslip of the innominate on the sacrum. A downslip would be the opposite. We can get posterior rotations of the innominate on the sacrum, and so this is like a posterior pelvic tilt, but occurring only on half of the pelvis. And so when I try and think about these rotations, what I like to do is take my thumb and index finger of both hands and then put them together so it creates a circle. And so your thumbs will be close to your body, your index fingers will be pointing away, but thumbs are touching thumbs and index fingers touching index fingers. And so if this created a pelvic ring, and we have a right innominate and a left innominate, with the thumbs being where the sacrum would be, a posterior rotation would result when your right hand, for example, thumb moves down towards the ground, index finger moves up towards your face. That creates a posterior rotation of one innominate on the other, or one innominate on the sacrum. So that would be a posterior rotation. Similarly, if you were to take that right hand and rotate so that index finger moves towards the ground, thumb moves up, you get an anterior rotation of one innominate on the other. Same hand configuration, but now if you keep your your index fingers together and you separate your thumbs by moving your right thumb away from your left thumb, you can get an in flare. So the ASIS is turned more inwardly, and so we call that an in flare, or the opposite. You could keep your thumbs together and move your right index finger away, and you get an out flare on that side. And so these are some common things that we'll see going wrong with the SI joint, but I want to remind you that there is a whole school of thought that starts to look at motions such as these not only occurring in one plane, so an upslip, downslip being in one plane, the rotations being in another, and the flares being in yet a third, but dysfunctions occurring in multiple planes, and not just the innominate moving on the sacrum, but also the sacrum moving on the innominate. So you can see this could be quite a detailed area to try and take a look at when you start to try and name the positional fault. So now as we start to look at some examination approaches to the SI joint, again I'm going to remind you it's building the preponderance of the evidence. So far we've talked about the kind of mechanism of injury to some degree. We've talked about the symptom location and the pain pattern. And then we had discussed that we're going to look at tests being in three categories: palpation-based, motion-based, and stress-based. So let's first look at the palpation-based tests. The purpose or goal of these tests are trying to palpate bony landmarks bilaterally and then make judgments about the position of those bony landmarks relative to each other. And so some common landmarks that we're using are ASIS anteriorly and PSIS posteriorly. Iliac crests are also commonly used to palpate and compare. As far as the evidence related to these tests, it's been shown that these tests have inter-tester reliability and agreement ranges from around 40%, meaning that if we have a patient in front of us that has what looks like SI joint dysfunction, and I do a palpation-based test, and then come to a conclusion, and then hand the patient over to you, and you do the same test, we will agree in less than 50% of those cases. So around 40% of the time we'll come to the same conclusion, given the same patient at the same time, not knowing what each other concluded prior to comparing results. And so there's poor inter-tester reliability of these palpation-based tests. And part of the reason is, as we've discussed way back earlier in this block in lab, we're just not really that good at palpation. Within ourselves, we're pretty good at palpating and finding the same structure, but our ability to identify and locate a specific structure between each other in our approaches and our decisions tends to be a little bit less reliable, less useful of a tool. So that creates a challenge with these tests. The other issue is that quite often these landmarks that we're palpating are often large bony landmarks, and identifying the exact same point on that large landmark on the right side to compare it to the left side can be a challenge. And then lastly, there's normal anatomic differences from right to left within people, and so those are common without any pathology. And so if you were to palpate these landmarks on a patient that had this anomaly, you might come to a conclusion that there was pathology based on that palpation of their normal anatomy, and come to an incorrect conclusion. So some of these tests. First one is palpation of the iliac crest. This is probably something you did in biomechanics or maybe in MC. But what you're doing here is you're palpating the tops of the iliac crests, placing index fingers on top of the iliac crests, and then visually examining the heights of the iliac crests. And what you're looking for is if one is higher than the other. And if you do find one higher, it may suggest upslip of the innominate that's higher, or it could also suggest downslip of the innominate that's lower. I just want to have you stop and realize that back in biomechanics, when you did this test, the purpose of the test at that time was most likely to determine if the patient had a leg length discrepancy. And so realize that if the pelvis is rotated in a frontal plane, because one leg is longer than the other, then you're going to see this test being positive. And so now you have to determine whether this positive result could be a result of leg length discrepancy, an upslip or downslip at the SI joint, if it's just their normal anatomy, or if you've mistakenly placed your hands and then came to an incorrect conclusion. The next palpation-based test is palpation of the PSIS heights. And so with this test, what we're going to do is palpate and find the PSIS, and then visually examine the heights of our fingers that are palpating and make a determination of whether one is higher or one is lower. And when we palpated PSISs earlier in lab, we described an approach to doing this that might make it easier to find the same point on the PSIS by palpating downwardly along that large PSIS until you kind of fall off the edge and then lift back in and up to catch the hook of it. And that may help you to be a little bit more consistent and accurate in your palpation. The other thing with a lot of these palpation-based tests is what I'll do is first get my hands in the location of the structure, but then either look downward or close my eyes and just use my fingers to tell me where I am on that landmark without being visually biased. And then once I think I've found the same point on the landmark on the right and left, I'll take a look visually at the patient and make a conclusion, just trying to avoid any bias by watching what you're doing, and just really use your mind's eye and your palpating fingers. So again, with PSISs, that approach to find it. And then if you find one is higher, it could be an upslip of one or a downslip of the other. And so very similar to palpating the iliac crest. But now with rotations, again, if you put your fingers together to create that circle with two C's facing each other, thumbs and index fingers, if your thumb now represents the PSIS, and you decide your right one was higher when you palpated, if you turn your right hand, index finger down, thumb up, the result is you get a higher PSIS, which is your thumb, and it resulted from an anterior rotation on that side. But at the same time, realize that you could get that same resultant positional relationship by creating a posterior rotation of your left hand on your right hand by moving your thumb down and your index finger up. The result is the right PSIS is higher than the left. The next of the palpation-based tests is palpating ASISs. And so again, same thing, you've got to find that same point on the ASIS, both right and left, before you can make a conclusion. And then if you find that one is higher than the other, again, it could be an upslip on the higher side, a downslip on the lower side. And if you go back to the circle created by your fingers, index and thumb, if we were to take with the right hand and drop the index finger down, thumb up, the result would be that the index finger is lower on the right, which is now the ASIS, and an anterior rotation on the right leads to the right side being lower. Also, we could create that relationship by doing a posterior rotation of the right hand, leading to the posteriorly rotated side being higher. So again, you've got to look at the results to make a determination. Before we move on, I just want you to stop and think that you can start to put the pieces of these tests together. And so by that I mean, let's first create an anterior rotation of the pelvis on the right. So with your thumbs and index fingers together, if you rotate your right hand so index finger drops, thumb moves up. If we were to do iliac crest palpation, the result of this rotation doesn't really create much change in the iliac crest height. So that test would be negative, or you'd find iliac crests are equal bilaterally. But if we palpated PSISs, we'd find that the right PSIS was higher. And if we palpated ASISs, we'd find that the right ASIS is lower. And so you start to see some consistency among these tests when you're especially considering these positional faults. Another example would be if we created a right upslip. So in this case, both index and thumb move upwardly or superiorly on your left hand. And so now if we palpated iliac crest, we'd find a higher right iliac crest. But when we look at PSISs, we'd find that the right PSIS is higher. And as we looked at the ASIS, we'd find that that right ASIS is also higher. So again, there are some patterns to these positional faults that we can find with some of these different positional diagnoses of the SI joint. I just want to remind you that the difficulty lies in our ability to consistently palpate the same landmark or the same bony prominence on a landmark, right and left, and then again within patients. And so that reliability of these tests is somewhat under challenge. I'm not suggesting you don't do these tests. I'll just remind you that we said the goal here is to build the preponderance of the evidence. The next group of tests are motion-based tests, and the purpose of these tests are trying to make judgments about movements that are occurring in these landmarks that we're trying to palpate, while the patient does a variety of different lumbar and or hip motions. Okay, and so the challenge with these tests are that we're trying to identify whether one side is moving more or less than the other when the agreed upon maximum amount of motion is in this 3 to 5 millimeter range. It stands to argument or that these tests would be a challenge. So some of the evidence related to these, again, found poor intertester reliability for these types of tests. Other investigators have found similar results when looking at these tests. So again, what we're saying is if we have this patient that presents with what looks like SI joint dysfunction, and you do some of these motion-based tests and come to a conclusion, and then I do them or a classmate does them and come to a conclusion, we may come to different conclusions with the same patient doing the same tests. And so that really challenges the value of these tests clinically. But again, I'll remind you, we don't just stop doing them because SI joint dysfunction is difficult to diagnose. And so we still do them, again, trying to build the preponderance of the evidence. And again, the difficulty with these tests is it's hard to palpate these landmarks that we're going to use to judge motion, and then there's such a small amount of motion, it's difficult to determine whether there's more or less motion on one side compared to the other. So the first motion-based test is called the sitting flexion test. And so what we're doing with this test is we're palpating the PSISs. So we're getting thumb hooked under the PSISs on the right and left. The patient's in a seated position. If you're going to do this on a plinth in the clinic, what you want to do is make sure their feet are supported so they don't feel like they're going to fall off the table, or lower the table so that their feet are on the floor. And then the patient's going to separate their knees and just slowly drop their trunk down through their legs to flex forward as you palpate and track the PSISs. And the goal of the test is to try and determine which PSIS moves first or which one moves farther, sort of anterior and superiorly, cranially. So you then base your conclusion on which one moves first or farthest. So if the left PSIS in this case were to move first or farthest, we would conclude that this would be a left-sided SI joint problem. And so let me try and explain what's happening with the test. So now what you need to do is either visually look at a a pelvis with a sacrum, or imagine, which is a little more challenging. But as the patient flexes forward, motion will go from superior to inferior in the spine. So it'll work down through the lumbar spine. So L2 flexes on L3, then 3 on 4, 4 on 5, then 5 flexes forward on the sacrum, and then at that point the sacrum would flex forward on the pelvis. Remember that we've agreed that there's the ability for 3 to 5 millimeters of motion in the SI joint, and so that sacrum could flex forward 3 to 5 millimeters on the two innominate bones of the pelvis before the pelvis would then begin to roll forward, flexing at the hip. If one SI joint was stuck, okay, so there was no motion at that joint, as I flexed down through my lumbar spine, got to L5 flexing on S1, when I hit end range there, and the sacrum wants to move on the right and left innominates, if one side is stuck, no motion will occur there, and motion will immediately occur with that innominate rolling forward. While at the other side, the 3 to 5 millimeters of motion is occurring before that innominate starts to move. And so the side that moves first or farthest with this test is the involved or stuck side, the side that does not have motion. And again, we'll work on this in lab. And then you compare your results here with a standing flexion test. And the difference between the sitting flexion and the standing flexion test is that in this position the hamstrings are eliminated, or if the patient has tight hamstrings, the effect on the test is going to be eliminated. So the standing flexion test. So with this test, it's very similar to the sitting flexion. You're going to palpate the PSISs. Again, the picture doesn't show it, but we'd recommend hooking the thumbs under the PSISs. The patient is then going to slide their hands down the fronts of their thighs and create a top-down flexion motion. So that motion moves down through the lumbar spine until it reaches the sacrum. Once it hits the sacrum would move on the pelvis 3 to 5 millimeters, and then the pelvis would roll forward at the hip as you continue to flex forward. The side that moves first or farthest cranially is the involved side, and so this process is the same as described in the sitting flexion test. The difference now is that we are involving the hamstrings. You should find the same thing both sitting and standing if it's an SI joint problem. Again, the reminder is difficulty in palpating that same landmark, and then the challenge of identifying a difference in motion when the maximum is 3 to 5 millimeters. Okay, and so we compare those results. The next test is Gillette's or Gillet's, or the standing stork test. And now what you're doing, and this always gets confusing because in the previous two tests we were looking at PSISs and comparing motion. Now what we have to do is the test in two parts, and we're going to test the right and then we're going to test the left. So in this picture, they're testing the left SI joint. So in the picture, the person's right index finger is on S2, and then the index finger of the left hand, and we'd recommend you use thumb under PSIS, but is palpating the PSIS. From a standing position, you then ask your patient to flex, and if you can see in the picture, they have their hip pretty well flexed up to their chest. But they're going to pick up their the testing side leg, flex at the hip, and they need to get beyond 90 degrees of hip flexion. And they're going to do this more or less passively using their upper extremities to pull their leg up into flexion. As they do that, you're going to palpate the motion that occurs between the PSIS here and S2. Now, I want you to consider that this is motion that's occurring from the bottom up. So the hip is flexing and hitting end range of hip flexion. This is why you need at least 90 degrees. And at that point, the pelvis starts to posteriorly rotate. And that motion would be occurring on the pelvis on the sacrum. The result is that the PSIS on that side should drop. And so it should move kind of in a down and out pattern or motion pattern, pathway. And so we're going to look at how much did this PSIS move relative to the S2, and then repeat the test on the other side, looking at, and so if I flip the picture, S2 and right PSIS. So I perform this on the left, look at the change in position, PSIS to S2. Perform it on the right, look at the change in position of PSIS to S2, and make a judgment of which one moved farthest. Okay, so the uninvolved side moves the farthest. So again, this is a source of confusion when you think about sitting and standing flexion and then Gillette's. Sitting and standing flexion, the one that moved first or farthest was the involved side because it was the stuck joint. Now the one that moves farthest is the uninvolved. Okay, and so it's saying that there is motion occurring at the SI joint when it moves farther, and when it doesn't move as far, let's say there's no positional change from standing to this flexed position, no position change, we're going to say that that joint is stuck. There is no motion occurring there, while the other one moved farther, the positional change. And so again, we use S2 as the reference point. The last of the motion-based tests, kind of I think the most interesting, but the poorest of all of them, and probably the most commonly performed in the clinic, is the supine to sit test or the long sitting leg length test. So to perform this test, the patient is positioned, and we're going to spend some time on this in the lab, so let me just give you an overview, and then we'll talk about it more in lab. Patient is positioned supine. You're at the foot end of the table, as in this picture here. Ignore the fact that she's sitting. This is the end of the test. But in this position, we're at the end of the table, patient's supine. We palpate the inferior-most part of the malleoli, medial malleoli. And our first step in the test is to judge whether they're equally positioned, or if one seems more farther down the table, suggesting a leg length issue. So we first assess medial malleolar evenness in supine. We're then going to assist the patient up to a long sitting position. And again, we'll talk about it in the lab, but you end up in this position, and then we reassess the malleoli in this long sitting position. And here comes the challenge. So what I'm going to try and explain here, just using this picture to start with, is the picture here is supine and here is sitting. So start position, finish position. If we first look at position B, we're going to call this the normal, B and B. And in this situation, B, or these black circles, represents the acetabulum, or the hip joint. And if you think about the pelvis from this view being circular with an axis of rotation right here in the center, it almost looks like this could be the face of a clock with its axis of rotation here. So B is the normal, and in this situation the acetabulum is positioned around 2 o'clock on our clock in supine. And as a person goes from supine to sitting, the effect of that pelvic rotation, rotating from this horizontal orientation to this vertical orientation, is that the acetabulum moves first more caudally or towards the foot end of the table, halfway through that motion, and then for the second half of the motion starts to move more towards the head end of the table. The effect is that the length of the leg, the apparent length of the leg, or its position on the table, starts in one position, appears to lengthen halfway through the motion, and appears to get shorter halfway through the motion. And that's the normal typical. Again, we'll see this in lab. If we look at A, this is supposed to suggest that the person has a posterior rotation. Okay, so for now, just ignore what the words say and just listen to what I'm describing. If the person had a posterior rotation of this involved side, or the side that we're looking at, if you use your fingers and thumbs to make that pelvic ring, to create A on the right side, you would lift your index finger up and your thumb down on the right hand. And that creates a posterior rotation. The result is, in the pelvis, that posterior rotation pulls the beginning point of the acetabulum into this posteriorly rotated position. In effect, it goes from 2 o'clock to 1 o'clock. As your patient goes from supine to sitting, the position change of the acetabulum is going to move from what looks like a 1 o'clock position on our clock to a 3 o'clock. So when we look at medial malleoli and supine, this is our involved side on the right. We could consider B being the left side, uninvolved, normal, typical starting position. And if we projected the legs down from these acetabular starting positions, we would come to the conclusion that the right leg was shorter than the left leg. As the person moved to sitting, the effect would be that the right leg would lengthen the entire time or move further down the table, while the left leg, normal, uninvolved, would get longer then shorter, no net change. And so now the result is, in long sitting, the involved side looks longer than the uninvolved when you compare medial malleoli. So if I have a posterior rotation, I would see the involved side starting shorter in supine and finishing longer in long sitting. Okay, so this is what you have in your handout, and hopefully that started to make sense. We could describe the same thing with C representing an anterior rotation. The result would be in supine, the involved side malleolus looks longer or further down the table, but when they move to long sitting, it gets shorter or moves up the table, and it goes from longer in supine to shorter in sitting. So the test is kind of a neat test, makes sense. The challenge is, and this is down here, way in the bottom, but it says there's many sources of error with this test. And so realize we're making a judgment about the position of the acetabulum to suggest whether the innominate has rotated, and we're judging it from the malleolus, and we're recognizing that the amount of rotation that might have occurred is maximum of 5 millimeters. We're also realizing that people can have discrepancies in their leg lengths, and there's a variety of other sources of error related to pain and position on the table that we'll try and address with technique of the test, but still creates potential for error. So it's a neat test, commonly performed, but a very poor test as far as its diagnostic value. Stress-based tests are the last group of tests that we're going to talk about. And with these tests, what we're trying to do is impart a force at the SI joint to see whether that mechanical force recreates or has an impact on the patient's pain that they're there or are complaining about. So they're comparable sign. And as I had suggested earlier, there's a lot of evidence starting to come out that these tests have a much higher reliability and validity, as well as some good sensitivity and specificity for some of the tests. But their ability to be completely diagnostic is still somewhat challenged, and so they're the best tools that we have. And so again, evidence-based practice, we're starting to get better at identifying these patients, but again, preponderance of the evidence. The issue is that there's some information that suggests that these tests can be positive in the patient that does not have SI joint dysfunction. So that creates the challenge to their clinical value. I think where some of that false positive comes in is that when you do these tests, if you ask your patient, does this hurt, you'll commonly get a yes, and you'll find that when we do these in lab that, yeah, it could be described as pain. But if you ask your patient, does this produce or increase the pain that you're here regarding, the answer may be different. And so we really have to assess the effect of the test on the patient's comparable sign. So we're going to show you 5 different tests: the thigh thrust, the pelvic distraction test, the pelvic compression test, the sacral thrust test, and the pelvic torsion test, which can be torsioned anterior and posterior on both the right and left. And the goal of the test is you progressively increase the amount of force that you're applying in an attempt to recreate the patient's pain. Again, they're comparable sign. And there's good evidence coming out to support the use of these tests to diagnose SI joint problems. And as I had suggested, there's some question over validity of some of the tests. And just so you understand, the way that they tested the value of these 5 stress-based tests were that they would perform the test, determine the results, and so thigh thrust, positive or negative, pelvic distraction, positive or negative, work their way through the 5 tests with a patient. They would then inject an analgesic into the SI joint of that same patient and re-perform the tests. And so the thought here is if it's truly SI joint dysfunction that was producing the pain or increase in pain with a stress-based test, if you numb the joint, that pain should go away. And so they were able to determine that, in those patients that the test was positive prior to the injection and then negative afterwards, that they truly did have SI joint problems or dysfunction, and then they could start to look at the validity, reliability, as well as sensitivity and specificity of those tests. Again, if you increase their pain, but numbing the joint didn't resolve the pain with a test, then you're getting false positives, which is a challenge to the value of the test. Okay, and so this is what I was just describing, comprehensive patient examination. They do the SI joint pain provocation tests, which are the stress-based tests. They do a diagnostic SI joint injection. Diagnostic meaning the way to determine if your pain is from the SI joint is if we numb the SI joint and your pain goes away, we know the source of your pain. And here's what they found. The thigh thrust, the sensitivity, and again, sensitivity would be if a test has high sensitivity and the test is negative, you can rule that diagnosis out. So this test, the thigh thrust, has high sensitivity. So again, if you perform this test and it does not impact their comparable sign, you are able to start to rule out SI joint dysfunction. Specificity of the test, a little bit lower, still somewhat of value. Again, specificity means that if the test is positive, you can rule the diagnosis in. So this test is better used to rule out SI joint dysfunction. Pelvic distraction, almost the opposite of the first test, the thigh thrust, as far as its values. This test is better at ruling in SI joint dysfunction as the cause of the problem based on its specificity. Pelvic compression test, again, generally good sensitivity and specificity, but probably a little bit better negative predictive value here, meaning that we can start to rule out the diagnosis. Sacral thrust, and again, we're going to teach you how to do these tests and let you practice them in lab, and I think that's better done in lab. But again, values for negative predictive value suggest that this test is a value in ruling out. And then this pelvic torsion test, and slightly different values comparing right to left. Not sure I can explain why, but the differences are so minimal, and I'm not sure that it's of concern. But again, a good test for ruling in SI joint dysfunction is the problem. So what? Before I get into describing this algorithm, the first thing that I want to say is the evidence tells us that when we do these pain provocation tests, if a patient has 4 out of 5 positive, you have a rationale or strong reason to conclude that this patient's pain is SI joint in nature. If you find 3 out of 5, you have some ability to suspect that it's SI in origin, but obviously less diagnostic. If we look at this algorithm now, here's the way that this is read. The patient presents with buttock pain with or without low back pain. Okay, so again, typically the pattern is without low back pain, but if we get this patient who we're suspecting maybe presents like a lumbar but not responding like lumbar, and we're thinking it could be SI, we could do, and with this algorithm, the two best tests are the distraction and the thigh thrust. Thigh thrust good for ruling out if it's negative, and distraction good for ruling in if it's positive. And then the question is familiar pain, so they're comparable sign, provoked by both? If yes, you can diagnose SI joint, because we know that when we inject the SI joint to numb it up, when these two tests were positive, more often than not the patient's symptoms went away, and so we can conclude that's SI joint. If no for both, now what we need to do is start thinking about some of our other tests. So if no for both affecting their comparable sign, we can do the compression test. If two of the tests are positive so far, so this assumes that, let's say, if no for both and yes for this, it would result in no for this. And if the compression test did provoke their pain, then yes. If one was positive up here and one was negative, and compression then was positive, we'd end up with yes, two tests are positive, so yes, SI joint. Again, same kind of thought process. If compression test was negative, so again, if we got two, so let's say we got only one positive, one negative. Okay, so no, we don't have two positive, so we're going to do the compression test. If that's positive, then yes, we're going to conclude. If no, then we're going to try the sacral thrust test. If that provoked their pain, do we have two tests? And again, we're trying to just build that evidence. And so if we end up down here that sacral thrust we didn't have two tests positive, no, all SI joint tests are negative. So if yes, all are negative, rule out SI. If one is negative, one is positive and the rest are negative, so are all SI joint tests negative? No, we got one positive. SI joint pain is unlikely. So you can see the order in which you apply the tests based on their diagnostic values will help you to conclude whether this patient has SI joint. So evidence-based practice in SI joint suggests that we use these pain provocation tests as our mechanism for diagnosing SI joint dysfunction. The difficulty is these tests have no real ability to tell us what the positional fault or problem at the SI joint is. They just tell us that this patient's pain is coming from their SI joint. So again, it's best to combine tests. So the history, what was the onset of their symptoms, where's their pain? Typically SI joint dysfunction presents as unilateral pain that extends down into the buttock, doesn't cross the center or over to the other side. Again, they can have some posterior thigh pain, they can have some anterior pubic symphysis pain, they can have some groin pain. You can do your palpation-based testing, your motion-based testing, realize the difficulty with both of those tests, and probably your best tests are your pain provocation testing. And then as far as treatment, we're going to cover this in lab, but what we try and do is basically take the SI joint that's stuck and not moving and either reposition it or get it moving again through muscle energy techniques, mobilization techniques, or manipulation techniques. And again, you already know one, the regional lumbosacral manipulation, the one where you start in supine and twist the person up and thrust through the ASIS. Or stabilization. And so, again, we can conclude treatment-based classification. This person either needs to move more or, in the second case, move less. They have a hypermobile joint. And so in those cases, we're trying to stabilize things. And we can use external belts. We can do a lot of stabilization exercises, especially exercises related to the pelvic floor, to try and create some stability. So the goal with treatment is always to reduce any misalignments or malalignments that we've been talking about, restore normal motion, that should be in the SI joint, get rid of their pain, and then remember this joint really needs to be stable. And so as we've talked about with cervical, thoracic, and lumbar, really all of these patients need to end up getting on some kind of stabilization program. This is especially true at the SI joint. So this is the point where I'd stop and ask if you have any questions, but obviously you can't ask any questions right now. But certainly if you have questions, we'll likely address them in lab. But if they're not addressed in lab, certainly don't hesitate to ask. Again, I apologize for using a online lecture to cover our lecture for tomorrow. But I think SI joint is a good one. It's conducive to this format simply because we're going to cover what we just talked about in lab almost verbatim, but give you a chance for some hands-on practice. The other nice thing is you can watch and listen to this lecture as often as you need to. I'll also remind you that there is a handout for this lecture that's available in the PT office. Hopefully you've already picked it up and you had it with you as we went through this. So thank you very much, and we'll see you Tuesday.